Good morning or afternoon, depending on where you're calling in from today. We do have people joining us from around the world, so please do use the chat function to share where you're calling in from today. I'm Jody Hoyos, CEO of the Prevent Cancer Foundation. It is my sincere honor to welcome you to the annual Quantitative Imaging Workshop, hosted by the Prevent Cancer Foundation and presented in partnership with the American Lung Association. This is our 20th annual workshop. I hope everyone here, those who are joining us for the first time, and especially those who have been with us from the start, will join us in celebrating 2 decades of exploring approaches to CT imaging to make recommendations for optimized screening, increased access, and better outcomes. This group has made remarkable progress in the past 20 years, and I want to send a sincere thank you to this pioneering and passionate group that has truly been patient-centered long before that was a trend. Before we start, there are a few additional thank yous I'd like to say to those who work year-round on this event. First, our steering committee. Hailing from a range of disciplines, institutions, and geographic areas who work tirelessly to make this workshop a success. The group is led by Dr. Jim Mulshine, who is also the scientific director for the Prevent Cancer Foundation. Dr. Mulshine guides this group with his years of research experience that's backed up by his commitment and passion for lung cancer screening and public health. Also on the committee, we have Prevent Cancer Foundation's founder, Bo Aldeje, who is a big part of the creation of this workshop, Rica Vila, Raul San Jose Estepar, Anita McLaughlin, Bruce Pyenson, Al Rizzo, David Yakalowitz, Matt Cham, and Tochi Okuyoso. Thank you to each of you for making this valuable exchange of ideas possible. I'd also like to thank our sponsors whose support makes this event possible as well. Once again, we are grateful to our partner, the American Lung Association. We also thank our gold sponsor, Bristol Myers Squibb, and our bronze sponsor, Go2 for Lung Cancer. Before I turn over the mic, I'd like to thank our dedicated team. Special thanks to Adrian Harkness, Senior Manager of Community Education and Conference Planning, who heads up this event. I'd also like to thank Erica Childs-Warner, Heather Thompson-Mackey, Katie Davis, Jennifer Nyangoda, Lisa Berry Edwards, Sarah Mahoney, and Kira Meister. Conference consultants Liz Hall and Stacy Ogren, and our production partners Blue Ridge Event Production. I hope all of you tuning in today will continue to keep in touch with the Foundation throughout the year. Visit preventcancer.org to sign up for our newsletter so you can keep up with the latest news in cancer prevention and early detection. You can also find us on LinkedIn, Instagram, or whatever social channels are your favorite. And a quick reminder, you will receive a brief survey after the event where you can share your thoughts to help make next year's quantitative imaging workshop even better. Now it's my honor to introduce Dr. Jim Mulshine. Dr. Mulshine is a professor at Rush University, where he has served as Associate Provost and Vice President for Research, as well as Acting Dean of the Graduate College. Prior to joining Rush University, Dr. Mulshine was at the National Cancer Institute for 25 years, where he was on research faculty. Dr. Mulshine is an international expert on lung cancer, and we are grateful and proud to have him as the scientific director of the Prevent Cancer Foundation and as a leader of this meeting. His passion and dedication to improving public health for everyone is positively contagious and an inspiration to us all. Please welcome Dr. Jim
Mulshine. Jody, thank you for those kind comments. And it's a pleasure to be here. It's a remarkable thing that we've been able to convene this forum for the last 20 years, and we are deeply indebted to the Prevent Cancer Foundation for this opportunity. Now, without further ado, I'd like to get into some overview comments. And we're calling this workshop the Annual Chest Screening, Visualizing the Full Impact of 20+ Years of Smoking. And the reason why we're doing this is because we have a focus on imaging as a prism to interrogate the consequences of this smoking habit as we as a society, a global society, age. And what we're going to be talking to you about is some epidemiology that's long been understood, but we're also going to be focusing on the new tools that are emerging that allow us potentially to extract much more relevant public health information that we can bring forward, hopefully in achieving much more healthier outcomes. Next slide, please. Again, I'd like to echo Jody's comments about the importance of our sponsors in bringing us this pre-competitive discussion that we have in this area that is intensely public health oriented. And so there's not really product opportunities for many of the people that have helped bring us forward, bring us these conversations for the last 2 decades, and we are deeply thankful. Thank you. Next slide. So I'm going to, in my comments the next few minutes, talk to you about what we're going to try to accomplish in this workshop. And for those that are new to the workshop format, this is a working meeting, and we're going to be reviewing different topics from a technical, clinical, and public health policy type of perspective. We're doing this kind of comprehensive view because there's interchanges, there's touch points across these issues that if we don't align properly, we can wind up with, problems with delays that can hold back progress for potentially long periods of time. So it's important for us to have a forum where all different disciplines come and talk about how things are going, what are the challenges, and what are the potential solutions. So that's the goal. And we're going to focus this time looking again at the imaging signatures of early disease, especially early lung cancer. Because of the improving resolution and increasing sophistication of the computational analysis capabilities of medical images, we're going to be also considering the additional information that's routinely available from these annual screening studies. We're going to then systematically look at the technical, clinical, and policy directions that ensure that screening is going to be an accessible resource to the entire global community. We're going to be focusing heavily on issues in the United States and North America, but there's relevance across the globe. And we have, we'll be talking to Dr. Matthias Utkirk very briefly, who has been the leader of the European efforts in terms of screening evaluation. And they've had exciting results, and they are bringing forward this very similar service across the European continent and have collaborations elsewhere that really emphasize the global dimensions of this research and innovation effort that we're talking about today. And finally, we want to make sure that within these populations, there are less endowed fragments of the population in terms of their access to care. It's a global problem, and we want to make sure that the tools that we develop are as available, economical, and sustainable as possible so that we minimize disparities in the delivery of these life-saving approaches. Next slide, please. So what does this look like? Well, here's a report that was published last year from a focus that we've had really for the last several years, certainly strongly supported by the American Lung Association, in which we're looking at not only lung cancer, but lung disease in this heavily exposed smoking population that is the focus of lung cancer screening. And this is very strongly highlighted in 2 recent publications that came out of the LCAP experience and out of the National Lung Screening trial. And Dr. David Steiger led the investigation by the LCAP, and Paul Pinsky reported the results from the NLST, in which they looked at the frequency of emphysema in the supposedly asymptomatic population undergoing screening in those two experiences. And what they found was in the LCAP, around 24%, in the NLST, about 31% of the people screened had objective evidence of emphysema on their CT scans. Now, from both of these experiences, the vast majority of these patients were totally unaware at the time of the screening that they had any evidence of lung disease. So this is a very important finding in so much as lung disease is, depending on the setting, perhaps the fourth leading cause of premature death in the world. So we want to think about what we can do today in this regard. And so things come to mind such as smoking cessation, which is already something that's supposedly part of every lung screening effort. But we know that compliance with cessation efforts are not perfect. So we're thinking that perhaps this information about emphysema might be shared with the screening participants in such a way to reinforce previous messages and potentially lead to more successful cessation efforts. This is an example, and some individuals will say, well, most of the people getting screened now have stopped smoking. Well, fortunately, that's a growing truth. But for instance, in the Cascade pilot study being conducted in France, in which they're attempting to figure out how to best screen the French population, in the accrual by women in that study, which is an important focus of that because the European data on screening benefits in women is less developed as in men. The French accrual to that study is included 85% of the women signing up are current smokers. And so the smoking cessation effort is immensely important in that setting. So we want to stick with that. But there's other preventive measures, such as simple things such as physical activities and whatnot that we'll be talking about. Because, you know, as obvious it seems, in a setting in which we know physical activity benefits individuals with cardiovascular risk, we have no such data to really prove or deny that this has a benefit in emphysema management or in lung cancer management. So screening, annual screening and annual follow-up gives us an opportunity to have a scaffold in which we can start filling out information about the benefit of such services. So in that article that we published, we talked about a roadmap to start putting this together in terms of integrating in rational ways in clinical workflows and trying to organize the data, how it's captured, how it's reported out in systematic ways so that everybody is kind of clear on what is the concern and how that concern can be addressed in downstream management. Next slide, please. So to do this, Al Rizzo and his colleagues will have 2 sessions focusing on pulmonary disease and thinking about what are the opportunities, what are the challenges, as I discussed. In this regard, it's very important to understand that in the world of quantitative assessments of imaging, the quantitative imaging workshop is about that we think the most reliable value from all quantitative assessments will be looking at individual assessments over time, especially in settings where we know the clinical outcomes. We have the ground truth in terms of what signatures go on to clinically aggressive consequences versus what types of biomarkers potentially do not progress to clinically aggressive disease. And sorting that out is immensely important. And so that underscores the importance of developing these longitudinal databases with images and clinical outcomes so that we can construct what is useful in terms of a biomarker and in what setting. This is particularly important because we're going to be talking extensively about computational progress with tool development. Many of these are artificial intelligence types of tools. Well, again, we're going to have a session that we're going to be talking about the strengths and weaknesses of such approaches, and it spills over into all the sessions that are going to occur in the next 2 days. Next slide. This all is very abstract and very confusing and complex at some level. And that's a challenge because we have a primary care community, we have a screening populations that this is their body, this is their life, this is their potential outcomes. And we have to figure out how to organize this information in more accessible ways to the different communities involved in screening. And so one of the approaches that Dr. Rizzo's and his colleagues will explore is how tobacco exposure to an individual over time activates an immune system in a particular way. And we're just beginning now to understand the nuances of the immune response and the implications in terms of disease progression. And so it's going to be very important and exciting to hear the progress that has been made, even in just recent years. Next slide. So the question becomes, we have all these, incredibly exciting computational tools, AI tools, and yet we know that there's certain things they do very well, and we know that there are certain things that we have to be concerned about in terms of applying them in a situation where clinical disease management is the focus of the AI tool. And so we need to educate, again, the clinical community, the development community, and the public at large about what to expect and how do we make these tools more robust in terms of performing the kinds of clinical decision support tasks that we will be engaged in over the next couple of years in trying to bring the benefits of these tools into clinical application. And so we'll be talking about how do we talk about this? How do we talk about this with our various stakeholders? And one of the important reasons for this kind of discussion is because these tools are only going to be as good as the data used to generate the tools. And so that means we need donation of images and clinical outcomes from screening participants to be collected in such a way that we can interrogate the performance of particular AI tools moving forward. We don't have that yet. The preliminary AI tools that we're going to be hearing about are developed as a function of fairly limited data sets. And if we're going to have AI tools that are applied across nations, across the world, for old people, for older people, for men, for women, for different ethnic groups, for different people with industrial exposures, we have to make sure that in all these varied settings, that the performance of these tools is what we expect it to be. And we're not there yet, and we're going to hear about in this session from Dr. Rizzo, and then from the next session from Dr. Avila on how this work should proceed. Next slide. So we're also, because of the experience that we've had thus far with screening, aware of the fact that not only emphysema is frequently present, but there's also coronary calcifications that are consistently available to be read from the low-dose CT scans done for screening purposes. And cardiovascular disease is the leading cause of death across the world, leading cause of premature loss of life. And in fact, there was a recent New England Journal study that was a comprehensive analysis of global cardiovascular disease done by a consortium published in the last couple of months, in which they looked at all the different markers for cardiovascular risk. And it turns out there's 5 principal modifiable risk factors for cardiovascular disease. And I show the reference in the slide here. And basically, these account for the majority of overall risk, and in particular, about 20% of the risk of death. And so when you break this up and you look at it, it turns out the number one modifiable factor for cardiovascular disease is blood pressure. Now, blood pressure is something that we're all very familiar with. It's a test that we all undergo. Many of us have high blood pressure. Other people have intermittent high blood pressure, but it's something that we live with and we deal with. So from the cardiovascular disease perspective, this is a very interesting tool. At this workshop, what we've come to grips with is we don't have a blood pressure equivalent for either pulmonary disease or for lung cancer. And we now have this screening that's going to go on. Good thing to know. Okay, are we back? Okay, thank you. Peter, can we resume the slides? Thank you, Kara. Okay. So, as I was saying, cardiovascular risk is predicted by a number of factors, and one of the most important ones is blood pressure. It's a modifiable risk. We're looking for corresponding modifiable risks for lung cancer and COPD, and quantitative imaging may help us provide such things. And this will be key to successful management going forward. Next slide, please. We're going to be discussing very soon with our keynote and other touch points throughout the rest of the workshop, the ability to look at coronary calcium in the lung cancer screening setting, and the clinical relevance of coronary calcium dynamics as are currently being examined. There's some challenges because the cardiovascular community has largely used coronary calcium as a cross-sectional risk factor, a one-time risk factor. And in the screening setting, we're going to be looking at coronary calcium change over the periods of times in a number of individuals. So we want to look at it dynamically. And this change over time, as we've talked about, is potentially very interesting. But in order to ensure that these measurements are reliable, we have a number of technical and related problems that we have to address. And we're going to be talking about how to approach that in an efficient way. Next slide. This brings us to the point where we're going to look at important new tools. We're going to be thinking about how those tools could be used. We'll have a simultaneous challenge of, as we move these into clinical implementation, who compensates the people that can do these things to get these better performance types of characteristics in monitoring these populations. And so that introduces the next session of the meeting, the public health policy and finance piece that that we're going to have, led by our colleagues from Millman, Bruce Pyenson, and Anita McGoughlin from the GO2 Foundation, to talk about the policy implications as we start thinking about how to achieve more meaningful benefit. What does that mean in terms of technology? What does that mean in terms of investments? Next slide. Now, this is not a small problem. You know, there's billions of dollars paid in the United States alone for preventive care. And we have to look at how this has evolved successfully into routine management. And so this involves defining goals for payer quality metrics. This is a very complicated issue as well. We have to look at potentially the best of the alternative metrics that are emerging that may provide a more swift path to where we would like to be. And we're looking forward to those discussions. Next slide. There's also a certain amount of challenge in terms of what's going on right now in the payer world, in the healthcare finance world, is there's inefficiencies, and we have to understand them, and we have to understand mitigation strategies to avoid having those same problems complicate the progression of the tool development into preventive strategies that we've already discussed. And so there's going to be very important consideration of approaches to this challenge. Next slide. Then we have the final issue that we have to really wrestle with, and we've already touched on elements of this. Talking about cardiovascular risk, talking about pulmonary disease risk, talking about cancer risk can be quite scary to clinicians as well as screening participants. And we have to figure out how to organize this information in ways that is digestible in these various stakeholder communities. And we have to think about how to kind of organize the layers of information adaptively so that we can deal with this very disparate information in a routine, effective fashion. So we'll go into those discussions, and we have in our workout structure an opportunity at the end of the first day and the final elements in the second day, an opportunity to have group discussions across all the segments of the workshop to come to better understanding of the best possible solutions and the action items that we might undertake. Next slide. So communications is going to be a big focus for that. And there's very important elements to the communications, not the least of which is from a screening participant's perspective. When you start talking about all these different potential problems, a concern that is almost universal is how do we pay for such things? And so we'll talk about those strategies. Next slide. So we are really in an undertaking in the next couple of days, a exercise in how do we frame the screening conversation in a positive, productive way so that we can achieve progress. Next slide. The technical breakout is really key to this, because right now, the things that we're doing in trying to use information about very early disease in a consistent way to inform clinical decision-making has never really been done before. And so we have an exercise with the integration of the lung cancer screening and emphysema information that we will review with Dr. Avila and his colleagues to see how we start putting together this highway that we're going to be driving over with the screening process, but we are assembling it as we drive. So we're going to talk about the implications in terms of extracting more data and then proving that data is meaningful in some particular use. And so we look forward to those kind of conversations. Next slide. I'm going to stop here. I again want to go back to Jody's comments that this workshop is a very challenging type of thing to do. And we've only been successful to the degree in the last 20 years that our sponsors, our sponsoring organizations, Prevent Cancer, the American Lung Association, have allowed us to continue to have these challenging discussions. We've had support from other institutions. We have, as Jody outlined, incredible contributions from the steering committee, the faculty that's worked with us on these workshops, as well as the staff of both the foundations and from our technical colleagues from Blue Ridge, who hopefully will now have us on a line so that we can continue this conversation without interruptions. And then finally, I want to say that this is a workshop. And so everybody on the Zoom, everybody here at the Prevent Cancer Foundation headquarters is participating in helping us get the best ideas, discuss the options for how do we operationalize the ideas, and then how do we move forward in a sustainable fashion at a policy level to make sure that all people who need these services can get access to them. And I'll stop there. And at this point, we move to our keynote address. And I'll turn to Dr. David Yankelevitz for an introduction of our keynote speaker.
Thank you, Jim. I'm good. Audio? Okay. So it's really a pleasure to introduce this keynote address. I think it sort of summarizes all the exciting things that this workshop is doing, and I think everybody will be really interested to hear what our speaker, Dr. Morteza Naghavi, will be describing. He's going to be talking about AI-enabled chest CT screening for comprehensive cardiovascular disease, lung cancer, and COPD prevention. Just a word about Dr. Naghavi. He describes himself as an innovative physician scientist and entrepreneur. I think that's a wonderful description. He has made many, many academic contributions, and he has also been very successful in the entrepreneurial world with several startup companies, including some new startup companies that are doing some very exciting work. And I suspect we're going to be hearing a lot about that in his talk. He has led major initiatives, including the SHAPE initiative, which is the Society for Heart Attack Prevention and Eradication, that has done some wonderful work and really was a leader in coronary calcium scoring and getting it accepted. He also is leading a major initiative right now to get Medicare to reimburse coronary calcium scoring. And he's really taken this battle on with the support from leading cardiologists throughout the country. And he's assembled a team of people that are really pushing this. It's something that is very important. It should be very, very important to all the people on this call to be able to get this type of reimbursement. And I think it hopefully will lead the way to other types of reimbursement. So with that said, Dr. Naghavi, we're looking forward to your talk.
Thank you so much, David and Jim, for inviting me again. Can you all hear me okay? Thanks again to Prevent Cancer Foundation and the team that put this together. It's a tremendous work to bring all these speakers and esteemed researchers to one place. I had the pleasure of giving the same talk 4 years ago, right before COVID. And I think you guys invited me back to give a report card. So I take it as took it as a challenge. It has been a very challenging 4 years, but I'm proud and happy to share with you quite a bit of progress since when I presented this. And at that time, I had just recently started HeartLung.ai, and we became the first group to bridge the lung cancer, the field of non-cardiac findings in chest, and the cardiovascular team. As Dr. Yankelevitz alluded to, I have a unique situation, one leg in academia and a nonprofit. This is the nonprofit that I founded in year 2000, and ever since it has been pushing the boundary on early detection of coronary artery disease. And thankfully in 2019, after 15 years of aggressive and intensive advancement of the knowledge of coronary artery calcium scoring and atherosclerosis screening, it was adopted. Our SHAPE guideline was adopted in national guideline, and it is now part of American Heart Association, American College of Cardiology's recommendation for the intermediate risk population. We did not have their support when we started in 2005. Along with that, this was the initiative that SHAPE helped pass in Texas. Texas is still the first. I think recently New Mexico is added to this list that mandated a reimbursement for screening of asymptomatic population in the intermediate risk category with coronary artery calcium score. As Dr. Yankelevich alluded to, I have been carrying this burden and with passion and love to make the same thing happen national level with CMS. We think we have made quite a bit of progress since we've had now 5 hearings, and we hope over the next few months we will have significant advancement. So let's go back to our problem. What is the problem? The problem is missed early detection opportunities, and I show it in this slide. It's really shocking when people, particularly those outside of our field, let it sink that only 3% of lung cancers are detected through screening, and not much better than that for coronary artery disease and cardiovascular disease, about 5%. The rest of them all by symptoms. We will wait, we wait, our patients wait, our population wait till there is a symptom, and symptom arises usually when the window of opportunity for intervention is very narrow. So that really simplifies our target, how to go about it. So what the solution we have been focusing on is to make early detection easy. How do we make it easy? We now have an amazing tool that we didn't have 20 some years ago, AI, similarly mobile app, and then mobile CT has become more of a reality. So that's really is these are the pillars of the solution that I present. And in our team, we have, which includes Dr. Yankelevich and a number of leading investigators, identified about 10 items that we can generate report from a regular chest CT scan, be it a cardiac subject who would have a broader view, or a lung cancer screening. So these are things that we put in our to-do list. We have not checked all of those, but I'm going to show you over the next few minutes that we have made quite a bit of progress. So let's go back to the solution again. So how do we bring this solution? This is the AI part that helps expedite, facilitate fast reading, and we want to have a first or primary reader, as Dr. Yankelevich's team referred to. But how do we do that? Well, we have to connect it to an easy way for people to access us. And that's what today we don't have such a thing. There is no direct-to-consumer app for medical imaging, for heart disease or cancer prevention, for reviewing medical images with physicians. So none of these exist. So this is our solution. We're going to build this. We have started. So over the past 3 years, this app is now in beta version of testing. People would download the app. They identify the nearest screening facility, CT scan facility. They schedule. They do everything through online. In Texas, reimbursement through insurance. Outside of Texas, partially covered and partially out of pocket. Then goes, they arrive, 0 paperwork, they scan the QR code, all information is available. They go through the scan time. If the patient doesn't have mobility issue and can easily get on the bed and get off the bed, it should not take more than 3 minutes. So we're averaging for 7 minutes in and out, and the data will be available by the time they get home, reviewed by a human expert, and as part of a continuum of care available to them through this network we call HeartLung. And the mission is to bring this to about 1,500 mobile CT units in the US, 3,500 for the rest of the world, in talks with WHO, and all of those would be powered by the same AI. So this would be really the only time I can think of where cutting edge technology in advanced developed countries in the heart of Manhattan, in Mount Sinai, could be available in a third world country in a mobile unit in China, in a rural area of India and such. So that's really the vision and the goal we're aiming for and working towards. So let's talk about some progress. When I presented in 2019, we didn't have this first FDA approval. Over the subsequent 2 years, we thought the lowest hanging fruit in this chest CT scan that has U.S. Preventive Task Force Services recommendation and reimbursement is bone density screening. It is a serious problem. A lot of us are not quite into it, but it was definitely outside of my area of expertise. But my colleague Matt Budoff and his team identified this opportunity in calcium scans and published quite a bit of publications in this. So in summary, looking in the back of a calcium scan or a lung cancer screening, I'm going to show you both, you'll find vertebral bodies. The trabecular bone inside the vertebral bodies are detected by AI. A certain algorithm goes into it and it's validated against DEXA. In summary, a DEXA equivalent report comes to practitioner and patients. I want to shout out to the man who first reported and validated thoracic versus thoracic QCT-based bone density versus DEXA and other techniques, and then followed by Matt Budoff and his colleague, Dr. Mao, published numerous, over 30 papers, validated various aspects of this technology. So back to the problem, it is a huge problem. We all know the population aging. With aging comes declining in bone mass and increasing in fracture. Some of the shocking statistics is that we have more osteoporotic fractures than heart attack, stroke, breast cancer combined in female. So that tells us we are focusing on a serious problem, and interesting and important finding in our chest CT scans. These are some of the slides showing when we did validation and presented our data to FDA. The manual method was very cumbersome. So AI and automation really made it fast. It's about a 5 to 7 minute technique to about 15 to 20 seconds with AI. And so Z-score, T-score reported, and then we correlated with DEXA again with our AI. Here we show, so in order to do a standardization of the report, we took 3 thoracic T7, T8, T9, approximately, that is common in all calcium score scan or calcium scans, and corresponding in lung cancer screening scans. And so we showed that the two are correlated. I'm not going to go into a lot of details. We published 2 important papers on this. Again, these are all progress reports since last meeting where I presented. These are not old papers. These came out in the last 2 years as part of our work. We went on, again, one leg in academia and publication, the other one in real world, that we made this possible for people to use. So this system is now in place. Practitioners, diagnostic centers, hospitals can go to provider.heartlung.ai, set up their packs through our AI gateway and our AI cloud, and get their reports within minutes after sending the images. Let's move on to what Dr. Mulshine referred to as an important finding in lung cancer screening. So we added AI to that. That's CAC. I don't want to go into details of the CAC part here because that has been published by other people and touched on quite a bit. But I'd like to share with you something that is truly innovative and has received FDA breakthrough designation. So that's a report card to add since my last talk here that our work has received FDA breakthrough designation, and there are only 2 FDA breakthrough AI in cardiovascular medicine so far. We have one of those. So let's talk about our AI and how, and again, it's part of the solution that I mentioned at the beginning. How does it work? Basically, the AI can measure the volume of cardiac chambers in a CAC scan or a lung cancer screening scan without any contrast agent. We trained the AI with contrast agent cardiac images, CTA, and the AI is able now to read it in non-contrast images. So a few examples I'm going to show you the magnitude of the discovery and the value that it brings. We all know CAC 0 in preventive cardiology is something to be so happy about and celebrate. If a patient has CAC 0, we usually give them a green bill of health. That's not true when you have enlarged cardiac chambers in the same scan that we currently cannot tell you about or see it. And this is an example, a female 57-year-old CAC 0 with our AI. We detected this person fell in the top 90th percentile. And this is from NIH-sponsored MESA study, MESA, that's multi-ethnic study of atherosclerosis. It's a longitudinal now reaching 22 years of follow-up, but we had 15-year of follow-up data, and we're surprised but expecting that enlarged cardiac chambers are not good signs, and this person had all 3, stroke, AF, and CHF. I'm going to show you our data for each one of these. This is another case. This is an older gentleman, but you do not find CAC 0 in a 78-year-old person. If you find it, this is fantastic. But again, missed opportunity for prevention in this person also. Enlarged cardiac chambers was not detected through a regular CAC report, and this person passed away with stroke and complication of heart failure. So I'm going to quickly go over some of the studies that we have gotten approval from MESA, NIH, and are in the process of publishing. Here we show that our AI, again, and I'm going to show you in a little bit, our AI works both on CAC scans and lung cancer screening scan, and the correlation is extremely high, and I'll show you briefly. So take that as given. This is the first paper we send out, New England Journal of Medicine AI, showing that our AI can detect who will have atrial fibrillation, not has atrial fibrillation, where you could use some kind of ECG loop or event monitors or tools like that. So the data is quite striking. You can see currently our standard of care is Charge AF. It's a risk factor type of calculator. Takes age, gender, blood pressure, treatment for blood pressure, smoking, and so on, and creates a score. Here is our AI reading the same CAC scan that currently is used for calcium scoring only, and reports LA volume, left atrial volume, and shows that those who are in the top percentiles of LA volume showed a significantly higher incidence of atrial fibrillation. And we showed that we were obviously calcium score was not a contender. We're just showing it here. It did not do anything. But BMP, which is used in a number of settings for as an added value for AF and a stroke workup, was not nearly as predictive. And the prediction was in as early as 1 year. So we could detect who will have atrial fibrillation within 12 months with our AI. There are a lot of details here in terms of AUC comparison and incremental value over traditional risk factor, which is encapsulated in Charge AF using our AI. And whoever knows NRI, which I see most of you are, and viewers, 0.8, 0.6, 0.7 is just fantastic NRI for any new test that added. Here, I'm trying to show you some general illustrations, just easier to understand. You know, AUC and all other things that are a little complicated. This is so obvious. CAC 0 versus CAC over 400, you can see the distribution of high risk and large cardiac chambers. So the yellow ones is a top quartile that's considered enlarged cardiac chambers, in this case, LA. And so you can see a significant amount of high risk people are a low risk CAC, and the same thing for LV. So that one was LA, left atrial left ventricle. And now you can see the same thing with Charge AF. So no surprise, we improved on Charge AF. You can see the Charge AF low risk has significant enlarged LA volume. The next study focuses on heart failure. Heart failure is a massive problem. As Dr. Mulshine said, we have blood pressure, and that's basically our main risk factor-based approach, but we cannot detect who has left ventricular hypertrophy. We don't know who has left ventricular dysfunction. They all come to calcium scoring if they do, and we see no calcium, we send them home. And here we show you that this population could be detected and put on a rapid and intensive treatment to prevent heart failure. So in summary, this paper shows that RAI outperformed NT-proBNP. Obviously, we outperformed Agatston score or calcium score. And here's the area under the curve. We refer to AI CAC is 0.82 versus all 10 risk factors. So we have 10 risk factors together. So you have to spend quite a bit of money to get all of these. Some of them are easy: age, gender, body surface area, diabetes, pre-baseline atrial fibrillation, so you have to detect that, current smoking, hypertension medication, systolic and diastolic blood pressure, HDL, LDL, total cholesterol, and high-sensitive CRP. All of that together could not outperform RAI, which was an opportunistic finding, a simple side finding on a CAC scan measuring LA volume. The third study is AFib. We show comparability with MRI. So we were lucky to have access to MESA, where 5,000 people, about 5,200, underwent both MRI and calcium scoring. And we show that, as you can see in the top one, calcium scoring and based, or AI CAC based LA volume and MRI are very much overlapping. So our measurements are very much the same in terms of volume of left atrium. And obviously the difference is massive. MRI, you have to go through MRI to get that dedicated. Here it's a side bonus finding, as Dr. Yankelowitz refers to, bonus, or we call it opportunistic. It is a bonus that comes from the same CAC scan or lung cancer screening that you go. So quickly through, we showed the same thing, comparability with MRI for heart failure. Both MRI and AI CAC predicted heart failure similarly. Those two are in top. Then below is BNP and Agatston score, a significant distance. This one for stroke, that's really a sucker. We all know stroke has the largest cost and morbidity and complications downstream. We show again MRI and AI CAC, a state in the top row. This one is CHA2DS2-VASc score. Most of you know CHA2DS2-VASc score is used for predicting risk of a stroke and recommending anticoagulation. So let's go quickly through this. And I'm just going to show you, again, the same common theme. We improve on the traditional methods of risk assessment using AI. Some of these I've already shown you, but this one I didn't. ASCVD risk calculator. It's a pooled cohort equation, which is basically, in the old days, we only used Framingham Heart Study. Now, 6 cohorts together pooled, and that's the foundation of calculating risk score in American Heart Association, American College of Cardiology guideline. So less than 5% is considered low risk. 5 to 7.5% is considered, this is a 10-year risk, considered borderline. 7.5 to 20% considered intermediate risk, and over 20% is considered high risk. So as you can see here, our AI improved significantly in the low risk population. So not about 19, 27%, 27, 27. It's just pretty striking that you can find high risk population in the low risk ASCVD risk categories. Same thing if you combine them with calcium score, which is called MESA score. MESA score combines calcium score and risk factors, the same thing. I'm just going to quickly go through this. LA, LV, the same way. I just showed you charge. This is CHA2DS2-VASc. So CHA2DS2-VASc score 0 to 1 is low risk. 2 is a little bit on the borderline of high, and then 3 and higher are high risk. As you can see, we have a significant enlarged LA in these 2 low risk population of CHA2DS2-VASc. And the same thing with LV. This is just super striking that we're missing these people by traditional methods. So let's go through, this was just a correlation with MRI, as I just mentioned to you. This is our ability to detect LVH, left ventricular hypertrophy, versus MRI, which is the gold standard, an AUC of 0.87 and 0.85 for male and female. It's pretty striking. Showing here in contrast versus non-contrast CT. So our AI works both on non-contrast and contrast. Obviously, the main value is non-contrast. That's where we want to get most information, but it works on both. Here is we show on CAC scans versus lung, full chest lung scans, the correlation. This is actually the lowest correlation. The highest correlation is LV wall mass, which is R square 0.956. So we did the same thing with echo. This was just a small sub-study at Harvard UCLA with those people who had echo and CAC, and we showed that our AI CAC was able to separate HFrEF, heart failure with reduced ejection fraction, with HFpEF, heart failure with preserved ejection fraction. This is the summary of all these findings. Basically, a drastic improvement AI CAC provides over traditional methods for risk assessment. This is a sample report that will come out. Again, I refer to, this is a report card from last talk that I gave here. So this is the most recent data. It's still being cooked, just literally out of oven 2 days ago. We're looking at the emphysema. So Dr. Mulshine referred to asymptomatic emphysema being common in lung cancer screening population. Well, it's pretty common in coronary calcium screening population as well. And here we show you the percentage of lung parenchyma with a Hounsfield unit of -910 and lower. And it's just amazing that such a high prevalence exists. Again, this is very fresh data, so I don't want to be presenting as final, but we see a significant improvement over smoking by looking at our AI reading these lungs, and there are some significant p-value for this added value. These two both are right upper lobe in terms of our reading from CAC scan. Again, this is calcium scoring scans. This is not lung cancer screening. Back to the problem. Missed early detection opportunities. I hope next time when I'm here, we have the entire 10 modules worked out, all available with the app, with the AI centralized and mobile units, but that's the direction where we're going. We're hoping that with the adoption of reimbursement, if we could get it at the national level, this whole process would be expedited. Mobile CT screening would be widely available. This is a very fresh topic in our team. I just got back literally last night from China, talking to some players that could help us in the execution of this plan. I want to give a shout to one of our team members, Rob Hedrick, who recently joined us. As you can see, Dr. Yankelowitz and others, Dr. Reeves, Dr. Hanshinke, and Dr. Zuleta, they're essential to my work here, been my advisor. He put this together, worked out all the details and stuff that really needed, and now he's averaging 55 cases per day for lung cancer screening in coronary calcium screening. He's a surgeon, thoracic surgeon, but really took this to heart, and I'm very proud that we have him as a young fellow in our team. With that, I'll stop here, and I thank you for your time and invitation. I'm happy to answer questions.
Well, thank you so much for that talk, Mort. You've been busy the last few years, and I'm assuming this may not be the only thing you've been working on. I'm a big believer in this approach. I think the idea of all of this added value is just fantastic, and the type of work you're doing is going to open up what we can do in cardiac. You know, the lung screening is a topic unto itself, and obviously we're all believers in that. But what you're opening up here in the heart is transformative. You know, you're going to be predicting AFib. You know, people with AFib, you know, the first sign people have of AFib often is they present with a serious stroke. That's their first sign. We're going to be notifying people, you know, who are coming in, have no idea that this is on the horizon, and we're going to be able to do something about that. You know, there are interventions for this. So this type of thing, I think, is you know, I like to say it's the future, but we really have it. It's really here. And I think throughout the course of this meeting, we're going to be discussing some of the challenges in how we implement this, how we get it reimbursed, which I know you've struggled with, and you've had to deal with all of these issues with reimbursement. Your experience is going to be very useful for us for how your struggles with getting coronary calcium reimbursed, how you've tried to work out how to get the osteoporosis reimbursed, which is actually a U.S. Preventive Task Force approved, and you're still having troubles with getting that reimbursed. So all of these things. And then how do we get it out to the people? How do we make people avail themselves of this? You know, screening, as you point out, people aren't doing it. There isn't enough lung cancer screening out there. So how do we get it out there? And part of your approach is to make this more and more available. So I appreciate all of the topics you touched on in this.
Thank you, David. I'm just going to say, you know, the uniqueness about this group and us is we don't just give talks, we actually go and do it. And so getting FDA approval, bringing CMS to the table, getting all these players, talking to WHO, fly to China, talk to people who have a way to do it. This, and of course, this has been because you've been a great supporter, and Jim, we've had several talks. I think this group has the potential to leave a significant, you know, impact on the field, particularly with cardiovascular screening, because if we get that covered, as you know, we will have a much bigger pie in lung cancer screening, you know, finding early, you know, indication of nodules, emphysema, and as Dr. Zuleta always says, emphysema is like a bed and ground for, you know, enhancing cancer risk or metastasis and all that stuff. So we might find opportunity that you don't have currently with lung cancer screening alone, because then we bring a bigger population to this. I refer to Dr. Marin. I think you invited Dr. Marin, who's a great advisor to SHAPE and a friend at Stanford. He shared with us a patient's letter. It was just beautiful letter. Thank you, Dr. Marin, for your lecture or your talk over there about calcium scoring. I went and got calcium scoring. Thankfully, my calcium scoring was 0, but they found lung nodule. And I went through the procedure. I got detected stage 3 lung cancer. Thankfully, I got it early and so on. And so we hope that with this effort, with this cross-bridging lung and heart, we'll be able to save a lot of lives and make a difference. So thank you again for inviting me, both you and Jim.
Dr. Naghavi, wonderful presentation. Enormously important findings from a public health perspective. One of the challenges in the world of calcium analysis is the fact that individuals going on statins, which are commonly used for risk management, alters calcium density. And one of the things that we're trying to figure out is, on a year-over-year basis, is this individual, whether they're on statins or whether they've changed their diet or whether they've done exercise or whatever, is this person getting better or getting worse? And have you taken that on in your enormous effort to try to figure out the dynamics of calcium turnover through time?
Yeah, I assume this was not a softball. You didn't know about our work. So let me tell you, yes, we put our AI to work for that. In fact, one of the key things that you would realize in monitoring people who are on statin is changing the intensity of calcification. So we put our AI to work, particularly for people in the range of 1. So CAC 0 is borderline 1 to 100. And we were able to show that by applying this specific patterns that AI detected, including the number of plaques and the intensity or density of plaque, we were able to distinguish. So a short answer to your question is yes, we can separate the effect of a statin, which is mostly stabilizing plaque, and making those calcification higher density versus expansion of plaque or spread of atherosclerosis, which would be lower density and more spots. So number of plaques increases, density is average or low, versus response to a statin, the number of plaques is not increasing, the density increases. So in both of these, Agassiz score increases. Unfortunately, that's because Agassiz score was, developed 30 years ago. So we called for an overhaul on Agassiz score as part of our AI CAC initiative, is to improve on Agassiz score and distinguish the effect of a statin and other things, lifestyle modification. In fact, exercise, you probably know marathoners have massive amount of calcifications. We know that they don't drop dead, with coronary artery disease left and right, except for, some strenuous activity that happens in some marathons. But generally, marathoners have good coronaries, but a lot of calcium. But their calcium, if you look at them, are very highly dense calcium. So statin, exercise, any other plaque stabilization interventions can increase the density, and AI can help with that.
Yes. David, were you going to say something?
Well, we have some questions from the audience, Jim. Did you want me to
Sure,
read that, or would you
sure.
like to?
We have a bit of time. Yes, that'd be great.
So the first question is from Jeffrey Borgia. Excellent presentation. Do you have an appreciation on if this approach has the potential to help bridge the gap with the underserved populations?
Well, this mobile CT initiative that I'm now extremely passionate about, do you know that, David? I pulled you into so many meetings. I have a lot of people coming in. That's our goal. In talking to WHO's president of World Heart Federation, Dr. Narula, we said, after decades, I'm from a third world country, from Iran, and he's from India. And we both have this appreciation of not having resources in those countries, in those villages, in the small towns, and so on. The whole idea is, if we put this mobile CT connected to a cloud, the same AI can give ordinary people, poor people, the same kind of access to preventive care. Of course, we cannot treat them right in the mobile CT unit, but we open their eyes. And I was talking to folks in China 2 days ago. I said, look, anywhere in the world, it's in America or it's a rural area, when you tell somebody you have cancer or you have this thing that is severely life-threatening, unless in an extreme situation, they do something about it. That is what we need to do, because most of the people who know, we know, 70, 80% of US population have one or more risk factors. They can't do anything about it. They're not doing anything about it. Obesity is still increasing, diabetes is increasing. But the moment you tell somebody you have cancer, they take action. So our goal is to bring this kind of actionable information through ease of use, mobile CT unit, app, AI, to a very wide population that will trigger. At the end of the day, it is healthcare consumer, who should be in charge of their health, not a physician. We already know that. We've already bankrupted the system the other way around. So the short answer to your fellow who asked this question is, that is our hope, that's our ambition and aspiration to go down this path.
Good. Next question. This is from Dr. Bruno Deman. To what extent is the AI analytics limited to a, quote, pre-read? And does every screening CT scan still need to be read by a radiologist? As the volume of CT scans increases, is that sustainable?
Yeah, so we have limited experience so far. So I can tell you about auto BMD. Our radiologist literally looks at 1 second, and that's it, pretty much, to just evaluate whether the region of interest is in the trabecular area and there's no mishap. About 4,000 or 5,000 cases that this one particular radiologist, Dr. Atlas, has done, 1 or 2 cases. So there's a tremendous amount of time saving. Calcium score the same way. Things that have measurements, we completely kind of turn it around for a radiologist or a human expert, because the time to do all those measurements are out, and you'll be able to get a quick look. So the short answer is, you would need still a human expert, but the time for that would drastically come down, and the number of reports and actionable reports and things that are easily understood by consumer significantly going up.
Yeah, I'll just make a quick comment on that. I think the time for AI to be actually making the reads and saying, without the radiologist looking for certain aspects, is coming, and it's coming quickly. And I think that to incorporate all the type of things you're doing, eventually, certain aspects of it just need to be totally done by the computer. And I think that's a good thing for everyone. The final question we have for you is from Professor Stephen Lamb. In your AI CAC, how do you take into account changes in volume between systole and diastole in a screening CT?
So good question. As you know, CAC scans, they're all around 75% diastole. So all of the data that you just saw was from that time. And it's amazing. We know MRI is end diastole, and we still have very good correlation. And it speaks for it, because the area we're measuring is substantial. Now, if we were measuring a very tiny amount, it would have been difficult. So short answer is, our data speaks for itself. In non-gated scans, lung scans that we showed, versus gated, we have for LV mass an R square of 0.95, for LV volume an R square of 0.93. So yes, they're not completely synchronized, but the volume and the area of region of interest that are measured is significantly large. If it was, again, a small, tiny coronary plaque, we would have not had this kind of correlation. So FDA bought our data. I mean, we went through a lot of scrutinies evaluating our results.
And finally, I have one more comment. This is from an interventional pulmonologist who was also a former fellow of mine, Dr. Hugh Matway at Hershey, Pennsylvania now. And her comment is, thank you. It was a very great presentation. I agree. So, Jim, do you have any final comments?
Yeah, Morteza, it was wonderful. It points out, though, we have a lot of work to do. And we've got to put together consortiums in which this massive amount of information that is being generated is kind of organized in a fashion so that we don't drown the clinicians in terms of conversations with their screening subjects, as well as figuring out where the ongoing management may occur. Now, maybe it'll be in a primary care office, maybe it'll be in a cardiologist's office, maybe it'll be in some kind of behavioral health scientist. I don't know, wherever it may be. We need to, as we deal with these types of data outputs, being many for cardiovascular, potentially many for pulmonary, because there's also an incredible amount of innovation going on in that field, as well as lung cancer. We've got an organizational challenge, and if we don't come up with some standards downstream from us, we're going to get people that are already potentially burned out, even more burned out. So there's just some practical things. It's spectacular to think about all these innovations, and now's the time to.
As you know, we've taken that challenge right up front. We wanted the report to be self-explanatory for consumer. I think we need to gradually kind of push the physician on the side as a consultant and just talk to people, just talk to the consumer, write a report for them. Let our AI write things that people can understand. And they now have ChatGPT and Bard. They can get this faster than any physician can, come explain to them. So I totally agree with you that we need to have a standard consortium. Now, I think thanks to David and you and Claudia, I think I've sort of created the first HeartLung consortium that we're building, but we should just focus on consumer and build everything that they would take, and physicians would be sort of consultant. That would be the right position for physicians to stay.
Yeah. I agree with you, but I think we also need kind of a runway for validation in which we can sort out which of these things, are robust enough to generalize in different settings. And, we mentioned David Marin. He's doing some work potentially with Picori about practical trials, pragmatic trials in clinical practice to start looking at these things systematically and assembling the evidence to support what you just said. And I think that today and tomorrow we got to talk about next steps in terms of moving into those pragmatic trials to try to get much more efficient approaches for validation than we've had in the past.
I guess it's a good thing we have a conference, Jim. We can talk about all these things.
Well, great framing presentation. Thank you very much, Dr. Naghavi.
Thanks so much for having me. Again, you guys will be a challenge. 4 years, hopefully in 3-4 years, not 4 years, maybe sooner, we come back and show quite a bit of more progress.
We certainly look forward to that. Thank you so much.
And we're looking forward to your participation in the panel discussions tomorrow as well.
Look forward to that. Thank you.
Okay, thanks, Mort.
Thank you.
Okay, so thank you, Dr. Naghavi. Thank you, Dr. Yankelevitz. Next, we have a celebration as part of this this workshop process. Prevent Cancer Foundation has created a leadership award, and I get to be honored by being the named person for this leadership award while I'm still alive. So it's kind of nice. And so we're going to honor this year Professor Matthias Udkirk from Groningen for his pioneering work in many ways. And so to do this, we have a video. And we'll have a video presentation, and we'll meet Dr. Udkirk, and then after that, we'll have time for a short break. So if we can now, we'd like to transition to our video. Oh, and to help us do this, we have Caroline Alderje, the founder of the Prevent Cancer Foundation.
More technical challenges, only they were my own doing. Good morning, afternoon, evening, whatever time it is in where you are. And that leads me to say how grateful we are that we have such an international representation. It's just amazing that we have built from being a national meeting in 2000, and then another one in 2004. So this is the 20th one in that series, into a meeting that we now are drawing participants from 13 countries. So welcome all of you, and thank you for those of you who are listening to us in the middle of the night. We really appreciate it. And thank you also for your patience as we work through the technological challenges. We now know what the limitations of our conference room are. I'd like to also echo Jody Hoyos's thanks in the very beginning of the day, when she extended our most sincere thanks, first of all, to Jim for being the visionary behind this meeting, and then to the steering committee, who spend literally countless hours getting this meeting organized and getting together. We couldn't do it either without our amazing team, both the team from the foundation, and Jody named so many of them, as well as our wonderful consultants, particularly Liz Hall, who is with us every single step of the way. And Blue Ridge, what are you, Blue Ridge Technology? Anyway, Bill, Peter, we could not do this without you. And then we want to thank particularly the American Lung Association for agreeing some years ago to partner with us on this meeting, because we're talking about lungs. And if it's not important to have the American Lung Association have their name attached to this meeting, I don't know whose name would be better. So Al Rizzo and Harold Wimmer, thank you so much on behalf of all of us who work year round to get this meeting organized. And finally, I would just like to recognize Simon Malia, who was kind enough, when we recorded this video of the presentation of the James L. Mulshine International Leadership Award to Matthias Udkirk in Singapore during the World Conference on Lung Cancer. Simon very kindly brought the video equipment and recorded the session, because it was really the only time that Jim, David, Matthias, and I could all be in the same room at the same time. So Simon, if you're listening in, thank you so much. And Bill and Peter, thank you for removing some of the background noise. Just as a FYI to everybody, we were in a big hallway in the convention center in Singapore, and it was not the most conducive to recording a video, but with all this technical support, we made it work. Now I think it's time for Jim to show the award. We had a stand-in award in Singapore, which is not the real award. And so Jim, in presenting the award and teeing up the video, presenting Matthias's award, will now show you what he really will receive. So thank you again for joining us, and we look forward to the rest of the meeting. Good morning. It is our distinct pleasure to present the 11th in the series of James L. Mulshine, MD, Leadership Awards to Professor Matthias Oudkirk of the Netherlands. I am now going to turn over the proceedings to Dr. Jim Mulshine, in whose honor this award was established.
Thank you, Carolyn. It's indeed a pleasure and an honor to be here for this event. I've been able to work with the Prevent Cancer Foundation for many years now, and they have been an organization that has focused on implementing important new directions in cancer prevention. They have done extraordinary work in the development of medical professionals that have moved into the field of prevention. They have done transformative work in the areas of colon cancer screening, hepatitis screening with hepatitis vaccination efforts. And so it's been wonderful to work with them. Today, we're talking about lung cancer screening. Their contributions in this regard have been quite significant. They hosted the meeting with the Roy Castle Foundation in the year 2000, in which all the leading researchers in screening got together, and in the wake of the discovery of lung cancer screening with spiral CT by the ILCAT group in 1999, they charted a path for validation of this finding with the National Cancer Institute. This meeting was very significant because it allowed the then director of the NCI to endorse these plans and move forward. Subsequently, the foundation has continued to work with the leadership of the NCI in driving forward this validation trial, which led then to the European validation trial, which was led by Dr. Oudkirk, and more about that effort. But this is an organization that appreciates important contributions for public health, and this certainly, the work today that we're recognizing has passed this high bar. Thank you.
Jim, shall we? Professor Oudkirk, congratulations from the Prevent Cancer Foundation on receiving the 11th James L. Mulshine Leadership Award. And now Professor David Yankelevitz will make a few remarks about the significance of Professor Oudkirk's contributions to this field, his important contributions to this field.
Thank you very much. So I have the pleasure of presenting the prestigious James L. Mulshine Award this year to Professor Matthias Oudkirk. I'd like to preface my remarks by saying I consider this a double honor to be here. First, because I have such high regard for the award itself as part of the Prevent Cancer Foundation. In the world of lung cancer screening, there has been no greater champion than James Mulshine, who has been so clearly involved in all aspects of CT screening from its onset back in, it really burst on the scene in 1999. And I say that Professor Oudkirk joins a prestigious group of prior recipients for this award. It was especially meaningful for his role in advancing lung cancer screening. Let me say a few words about Professor Oudkirk and why I believe he is so well qualified to be a recipient. I'd also point out that he has worked in areas regarding imaging aspects of lung cancer screening that I am highly familiar with, and I have spent most of my career working in these same areas. And that's why I'm so highly familiar with what he has done and appreciate his accomplishments and the impacts that it's had on the field. From his humble beginnings as an interventional radiologist, he's now professor of radiology at University of Groningen, and along the way, he was chairman of the Department of Radiology at Erasmus Medical Center at Groningen. He's also now the chief scientific officer for the Institute for Diagnostic Accuracy, which will have major impacts going forward on lung cancer screening. He served as the principal investigator for the radiologic aspects of the Nelson trial. This was really the key trial to convince the world of the benefits of lung cancer screening. I know a lot about that.
I was involved in the LCAP study, and I was quite sure when the LCAP presented its results, it would convince the world that lung cancer screening needed to be done. I was wrong. I then waited, and the National Lung Screening Trial came out, and I was convinced that this $250 million trial would convince the world that lung cancer screening was here to stay. I was wrong. Then the Nelson came out, and I said, boy, I really hope that this will convince the world. And it did. It really did. I think the doubt has been removed, and really Nelson really can take credit for being the one that really has put screening on the global map and made it really acceptable. In addition, the Nelson brought forward many innovations in imaging. And I believe the implementation that they did in terms of volumetric analysis is really one of the key contributions that that trial put forward. And ultimately, I think that will be, going forward, the main driver of having lung cancer screening be successful. And this, I think the Nelson Group can take a lot of credit for having implemented it so successfully. He's also the principal investigator on several other trials that are of great importance. The 4 in the Lung RUN study, a major European trial that brings together coronary calcium screening, lung cancer screening, lung evaluation, screening intervals, all in one trial. We eagerly await that trial's results. Similarly, he's the principal investigator of the Rubinska study for coronary artery calcium study, another major area that really is waiting on his results to impact how coronary calcium screening or scoring will become part of the national conversation, international conversation. He's also the principal investigator for the Nelson 3B study, a major initiative that took place in China, where they looked again at multiple screenings at the same time. All of these studies will impact lung cancer screening and how it's moved beyond just lung cancer screening to evaluate the associated benefits for other tobacco-related diseases. Ultimately, lung cancer screening will just be a part of all of these other things that we're evaluating. I think these trials will really assist in making that vision come forward. He has also been co-author of over 600 publications that have been published in some of the most prestigious of medical journals. But perhaps most impressive is his global interactions with partners throughout the world, including PhD exchanges and working with scientific startups. But I think from my point of view, and perhaps what I think makes him most qualified to receive this award, is the army of trainees that he has mentored over many years. They will make up the next generation of experts that will continue the work of lung cancer screening. Each year, I've seen wonderful presentations from students of Professor Utkirk, and to a person, they have great respect for his generosity and mentorship that he has provided them. Now, I also need to mention, and perhaps this is the outside reason that he's receiving this award, is that he, as I understand, is an expert in red wines, which I think is a key qualification that Professor Mulshine looks for in all of the awardees. And I also understand that he's an expert sailor and a devotee of classical music, but that's for another time. So it's my great pleasure to be in the position of helping to present this award to Professor Utkirk. Congratulations.
Thank you so much.
My pleasure.
Congratulations.
Congratulations.
Thank you.
Would you like me to hold this while you speak?
Now, of course, I'm extremely honored by receiving this award, especially since it seems to be the first international receiver of this award. And yeah, for me, it's also very nice to receive it from you, Professor Mulshine, Professor Naghavi, of course, from the founder and president of the Prevent Cancer Foundation. Yeah, I know, of course, you were ready for a longer time. Already 10 years ago, we met for the first time. David, I know for a much longer time. And when I started to implement the volumetry in the HeartLung trial, I thought I was original. So the doubling time, put that in a real perspective, not aware in that period. So it was in the beginning. I think we developed this in 2000, so that's a long time ago. I thought, okay, this is new, we will put it forward, and we did not have this communication through internet. You had to read everything in publications, you could easily miss things. And then far later on, I think it was about 8 years ago, we were both in Birmingham, and we had a dinner together, and I said, okay, it's very nice that the volume doubling time is implemented like this, and we also was very pleased by the fact that the Nelson study seemed to have so much nice results before the mortality reduction results came out. And he said, by the way, did you read my paper from, I think, 1999 or something in radiology, where I extensively put the volume doubling time forward? Now, we all know that pioneers, so he did all the work already himself, and he even has a patent on this. So, okay, I didn't know this, so I thought about the patent. I mentioned it to him, but he said to me, it's already there. So, okay.
You come collecting.
Yeah. So that was also a very, very, very nice meeting to understand that we work in the same direction, to find the same, what Jim also said, that you're working your way forward, and you have to really in this field collaborate with all those that see the same perspective, and there are many that does not see the same perspective. And I think, and that is also something that we share, that the imaging biomarker development is key for radiology. So the question arose, I think it was 10 years ago in the British Society of Radiology, that there was a key threat to radiology. Three threats. Now, one of those was that there was no negative predictive value really established with imaging methodologies. Second, there was not a real implementation of how we could monitor disease. So we all know that the RECIST criteria, they are now modernized, so to speak, but are heavily dependent on what we find with imaging results. And then third, which is also very important, that imaging biomarkers should be developed. So that is something of the British Society of Radiology that they already stated in 10 years ago, but nothing happened afterwards. And if you look to biomarker development in itself, from many companies, also biomarkers by definition, if you go to Wikipedia, you can find 10 different definitions. So there are not real good definitions. When I traveled through for many lectures through the US, through Swiss, and also through other countries in Europe, I would ask a questionnaire to radiologists and ask them, what is an imaging biomarker? And there was no consensus. No one knew what imaging biomarker was. So we worked on the definition, also to make it clear for ourselves. If you compare it also to the other ways that biomarkers work, we should come to a single unit, a single parameter on which you can make clinical decisions on. So that is very important. And if you think further than the quantification in all kinds of things comes in, because that gives you an exact measure. And that is what we are doing with volumetry, with doubling time, with calcium score, but also, for example, in the volumetry of the hippocampus, in the brain, and all kinds of diseases. So there are many, for example, choline measurement, spectroscopy, which when it's negative, more or less really excludes activity. metabolism of the cell membrane. So those are very powerful biomarkers in our field that we could use and apply and are there beyond the image. So, and that is what I think for the coming 20 years, we really should focus on everything that is in the data that we acquire, but is beyond the image. It's not visible in what the radiology is looking at. So, thank you very much for this honor. And I think the only way you can be honored is by people that understand what you're doing. And it makes it so very nice.
Congratulations.
Congratulations.
On behalf of the
Congratulations.
Prevent Cancer
Again.
Foundation. Congratulations.
Thank you.
So thank you very much. Thank you, David. Thank you, Bo. And of course, thank you, Matthias, for all your efforts and accomplishments and bringing us into a world in which we can start thinking about routinely being able to action information acquired from these thoracic CTs. We have Matthias on the line, and I just wanted to say that these opening sessions with Dr. Naghavi and with Dr. Utkirk's work, that we have a very fast evolving set of opportunities. And Matthias commented on the issues of standardizing the approaches so that this could be brought into clinical application in a more consistent fashion. We're really trying to focus on the core elements of that in this discussion. Matthias, I don't see you. Oh, there you are. In terms of what we've heard already from Dr. Naghavi and others this morning, anything else you'd like to say at this time in terms of moving this field forward?
No, I thought I looked better in Singapore than now.
You've aged.
No, I think the last remark I made is very very applicable to this meeting. That is, you need the people that understand the problems. So that is, I think, the great thing that you bring together here. That those are the researchers and the people in the medical science, but also the policymakers are in, and also businesses, startups, and I think all those, this whole network has to enable the next steps that we have to take. At the same time, what I heard from some of the people that had questions over there, I think it's extremely important, and you also stressed it in your comments. I think it's extremely important that we validate everything we develop. So, and that is, I think, also one of the core challenges at the moment, and that there's a real difference between the US and Europe, that we, from our perspective, we are in the middle, more or less. So in China, everything that's called screening is in fact a health check. In the US, I think there is an enormous impetus in terms of getting things reimbursed. I understand that it's important, it's part of the system, but it also provides you a kind of bias that in the ideal world you would not like to have. We all probably would like to work in an academic environment that's completely financed and then do the research in the way we wanted to do it, as if we were living in the times of Aristotle. Now, that's of course not possible. And what we have to find something that we here in Europe I think a little bit over stress a little bit, that everything has to be proved on forehand before we start anything. So that is especially here in the Netherlands. We have a special legal a legal framework here that we can only go forward with screening if there is an approval of the Minister of Health after a consultation of the Health Council. And that gives a different, that makes everything different. So you cannot just go forward. You have to come with real proven data. And that is why we do all those studies, of course, because that is to convince policymakers, to convince also the cost effectiveness, convince that there are more benefits than harms, and work into a big debate with very, very many critics, people that have a complete different mindset in this perspective. Now, when we were in Singapore, you probably remember that I referred to a German book 100 years ago, written by was before the Second World War, and the title of that book is, I still have it somewhere between all the books I have here, and it's called Grenzen des Normale und Anfang des Pathologisches Anatomie. And I think that is also an issue that here is very important. So with aging, there is a natural development of the aging process in the body itself. And that expresses itself, of course, in the skeleton, in the lungs, in the heart, in the coronaries. And what we are doing also is to benchmark this. So what is normal at a certain age? So when we started with, you probably are aware of the fact that we did also with my team the first, worldwide, the first non-invasive imaging of the coronaries. And we did this with, that time, one of the leading groups in coronary angiography. And they said, it's all nice, but when we see a stenosis, we have to fix it. So the coronaries have to be in the same shape. I said to them, so you think that the coronaries have to be in the same shape as when you are 30? Yes, of course, they say. Yes, of course. We have to fix everything, bring it back to that age, more or less. That's my translation. And I think that is not correct. So that is something we should build in also in what we are analyzing. So what is really making, what really makes sense? And then there is a relation between the age itself and the development of pathology, as the Germans made a complete atlas on, especially on the skeleton. Now, there we have this vertebra as one of the things that we can also apply in the analysis of what we will receive from our data. But here in the Netherlands, we are not really allowed to do this. So what we are allowed to do is now, and we changed also the nomenclature. So we said, okay, calcium and emphysema are proven parts of the mortality risk in the elderly population. So around 80% of all the population will die from those three diseases. So the impact of those three diseases is not really disputed. And therefore, we call it comorbidities. So we have the lung cancer, we have the calcium score, and emphysema as comorbidities and not as incidental findings. Because here in Europe, we would say incidental findings. Yeah, incidental findings, there are so many. Now we are in the middle of it, you know that, an implementation trial in Europe. And we see now that in every country, they want to report different incidental findings. So they have their own selection in incidental findings, what they find important. And it really helps now, I think, if we could come to a kind of consensus internationally, that we come up with, before others will do it, that we come up with this definition issue. So that we say, okay, we have comorbidities and we have incidental findings. Now with the comorbidities, we know, we have in the literature, or we did ourselves, enough proof that it really impacts the prognosis of a patient if you detect it early. On the other hand, you have incidental findings, and those incidental findings will not have any impact on the life expectancy. In fact, it has not been proven. So that should be, in my view, the separation we have to make as a research community. That makes our position stronger, because we are working with evidence-based outcomes. We should also, in my view, make a difference between screening and early detection and health check. So the health check is really should be separated from early detection. So health check would be something that is based on that is could be completely commercial, and that is something that you do privately, could be regarded as a kind of opportunistic screening, but has nothing to do with early detection in a program in a defined high-risk population and so forth and so on. Then the other thing is early detection, and there you have to define the diseases and everything related to it. And then in between you have the screening as a methodology. So that is what you do as a methodology, but not as a program. So screening more or less has in Europe an extremely negative profile. So we focus more on early detection in a programmatic screening fashion. So those are the remarks that I would like to make. From everything we discussed.
Matthias, thank you so much. And it sets up what we're going to cover in the next session. But prior to that, we have a 15-minute break where we allow people to get coffee and freshen up. Matthias, congratulations, and we look forward to your further participation in the workshop. Thank you all.
Thank you so much for the honor.
Cheers. Thank you. Okay.